Thank you so much, Kendra. You can all hear me and see the screen?
And hear me as well.
Yes, I can hear you.
Thanks,
Perfect.
Kendra.
All right, so we are going to present today on some strategies for overcoming vaccine fatigue to protect population health, in particular, talking about the pediatric population. So very briefly, and Kendra, thank you for introducing us. We just wanted to give a little bit more information on our background. I'm Dr. Jess Steyer. I'm a public health scientist with expertise in health policy evaluation. Andrea, do you want to?
Sure. Yeah, I'm Andrea Love. I have a PhD in microbiology and immunology, and my background focuses on host immune responses to infectious diseases, cancer immunology, and cell and gene therapy.
And so we launched Unbiased Science at the beginning of the pandemic in response to a lot of the misinformation that we saw swirling. We're actually friends from college. We remained in touch over the years. And even before COVID, I'm a mom. I'm in all these social media mom groups, parent groups, and I noticed a lot of misinformation about pediatric vaccines in particular, lots of fear mongering, lots of misinformation about, skipping vaccines, spacing vaccines, going to alternative schedules. And so Andrea and I were saying, we have to do something about this. And then COVID happened, and we wanted to use our expertise to help translate a lot of the information, the very technical scientific information for the general public. So a lot of our content focuses on vaccines, but we also talk about a variety of other topics in the health and science sphere.
Yeah, and I think it's also another focus of ours, and I've been really enjoying, the discussions on this panel over the course of the day, is also being a conduit for the very granular science for healthcare providers. So, healthcare providers are patient facing, and so they're really the people that they're going to be presenting the information to patients to improve vaccine uptake. And so, but at the same time, they don't have, the time or necessarily the specific expertise in some of these really granular studies to kind of tease out what information needs to be conveyed. So being a conduit or being a liaison to healthcare professionals as well as the public is really kind of the goal of what we do with regard to vaccine education, but also other topics that we cover.
All right. Of course, this isn't letting me. Oh, there we go. All right. So we're going to kick things off talking about vaccine hesitancy. We turn to the literature to help identify some of the factors that impact likelihood to vaccinate. And this goes for people themselves as well as vaccinating pediatric populations. So there are 4 general categories that parents list as reasons for not vaccinating their children. And broadly, they are religious reasons, personal beliefs and philosophical reasons, safety concerns, and a desire for more information from healthcare providers. Andrea, as an immunologist, can provide a lot more perspective on the safety concerns in particular, but we hear a lot about this fear that we're overwhelming the immune system with vaccines. And Andrea, I love when you make the point that, if we send our kids out to go play in the sandbox, they're exposed to more pathogens than they would if we were to combine all vaccines that are currently available at one time. So in contrast, we've also identified factors that are positively associated with parents' decisions to vaccinate their children. And these include mainly things that pertain to science and health literacy. So knowledge that vaccines are effective in lowering risk, duration, and severity of illness, receipt of vaccines by parents themselves, and the ability to recognize the importance of vaccination to prevent disease transmission in high-risk populations. We also can't ignore the sociodemographic factors that influence childhood vaccination likelihood. So there was a large 2019 national survey that found that children are less likely to receive their annual flu vaccine if their parents have lower education level, if their household income is less than 400% of the federal poverty level, if parents identify as white, non-Hispanic, and this is compared to Hispanic, if their household contains multiple children, and if parents are unmarried. We've also seen trends in geography. So when distinguished by geographic area, children in urban areas had the highest flu vaccine rates, with children in rural areas having significantly lower rates when compared to both urban by as many as 12.6 percentage points and suburban by as many as 7.4 percentage points for 8 consecutive flu seasons, regardless of the other sociodemographic factors that we just mentioned. And of course, we can't ignore the impact that the COVID-19 pandemic has had on vaccine uptake. So when we look, oh, sorry, Andrew, are you going to say something?
Oh, yeah. I mean, yeah. So basically, one of the phenomenons that has gotten exacerbated with regard to general vaccine uptake is obviously some of the sentiment related to COVID-19 and some of the additional politicization of vaccinations and science more broadly. And so, when you look at the messaging with regard to the COVID vaccines, the rhetoric and the messaging is very similar to what we observed in previous vaccination campaigns. A lot of things, which we're going to get into in more detail in a moment. But historically, there's always been a population of individuals that were opposed. Oh, Jess, can you go back for a second?
Oh, sure. Sorry. Yep.
So there's always been a population of individuals throughout the history of vaccines, even from Edward Jenner's cowpox inoculation, that were opposed to vaccination. And the reasonings behind it is just kind of summarized vary, and we'll get into kind of the granularity of some of that briefly. But typically it was not along partisan lines or by political attitudes. There tended to be pockets of individuals opposed to vaccination across all party affiliations. However, we are now seeing a shift in this mentality, and a lot of this has been indeed born out of the COVID-19 pandemic. So what we are seeing here, and this has been a series of studies, is that back as recently as 2009, even 2015, there really was not a difference in attitudes towards vaccination, particularly for children. So generally, there's always a population of individuals who have hesitancy or resistance to vaccination. But now we are seeing that this stratification is much more distinct, and we're seeing a much larger proportion of individuals who are resistant to vaccination that identify as Republican. And in contrast, we're seeing a shift in the opposite direction, where Democrat or individuals who identify as Democrats are even more likely to vaccinate their children than they were previously. And of course, this has led to some additional trends. Of course, there was a lot of conflict and discourse regarding COVID-19 vaccine regulations, mandates, and so on. But we are seeing these trends bleed into other routine childhood vaccination. So here's a couple of examples that we pulled out to underscore where, for example, the Tennessee Department of Health is now terminating all proactive outreach for adolescent vaccinations. So these would primarily be geared towards things like HPV vaccination, meningococcal vaccination, hepatitis B vaccination, but even other vaccinations, including things like MMR and so on. And then in April 2020, Colorado Republicans in the state legislature actually voted against having any sort of vaccination requirements on a state level basis. But there's a bit of a silver lining. So we did see some trends where we saw a drop off in vaccination rates for a lot of these childhood preventable illnesses like the MMR, like polio, and so on. DTaP is in there as well. A lot of that was due to people suspending preventative health and well visits. There has been a nice rebound in that, and I believe Jess is going to show some of those data in just a moment, but we are actually seeing some improvement in the rates of vaccination, particularly with regard to intentions for vaccinating children for annual influenza.
And Andrea, that's such an important point to make. There are a couple of different reasons or ways that the pandemic has impacted these rates. So as Andrea said, in the very beginning, we were all staying at home, right? So we were suspending any non-emergency visits to providers. But then that shifted to what has been labeled as vaccine burnout, right? People are hearing about vaccines, and we're hearing about COVID vaccines and boosters, and now people are just they're sick and tired of hearing about it. So we have a couple of different things at play here that are impacting vaccine rates. Here we thought this was interesting. This is the general trend for MMR vaccination globally over time from 1980 to present day. And you can see the impact of different factors over time. So we saw a steady rise since 1980. But then things plateaued in the 90s with Andrew Wakefield's falsified study linking autism and the MMR vaccine. And we'll talk more about that since that myth just continues to persist. Then we saw a steady rise through 2019 with lots of, this is demonstrating the impact of really fantastic public health education campaigns about the impact of vaccines. And then unfortunately, and we'll show in more detail on the next slide, we see a precipitous drop in vaccine uptake in 2020. So here we have a couple of different graphs here, different age groups under 24 months, 4 to 6 years, 11 to 13, 16 to 18. And in every single age group, you'll see that drop in 2020. So there's a clear gap in vaccination during the COVID-19 emergency in 2020. And unfortunately, we're seeing a resurgence of these previously eradicated and controlled diseases. So in 1992, there was the last confirmed case of polio in Malawi. And in 2020, we were all excited to announce that wild polio was eliminated in Africa due to vaccination efforts. But then, unfortunately, we're seeing these cases crop up. In January 2022, there was a young girl diagnosed with polio in Malawi. The reappearance of polio began just before the pandemic and then worsened because health services were, of course, shifted to pandemic-related health issues. But then also, as we just started discussing, pandemic-related vaccine hesitancy has contributed to a decrease in vaccination following the reappearance of polio in Malawi. And so this vaccine hesitancy, vaccine misinformation, it's an issue in the US, but it's also an issue at the global level.
And obviously, Jess has already alluded to this, but it's certainly multifactorial, where you have, especially underserved countries where it's a matter of access, resources, and what they simply have the bandwidth to do. But as the kind of thesis of our presentation, alludes to is a lot of this is due to social media and the impact of the spread of misinformation.
Here's another case study that we wanted to share. This relates to measles. So in 2000, endemic measles was eliminated in the United States. But then unfortunately, in December 2015, there was an outbreak of measles at Disneyland. So there were 45 cases in people who visited the park during the same time period. The outbreak lasted 64 days total, and there were 89 additional cases in California at the virus spread. And this correlates perfectly with a study that was conducted earlier that year in February of 2015. It was a case study at a clinic in California. It was a study of 110 patients, and only 1% of patients had 3 doses of the vaccine. 45% were unvaccinated, 43% were not sure if they were vaccinated or they didn't have documentation of vaccination. And then when you look closely at the unvaccinated vaccine eligible population, 67% were intentionally unvaccinated because of personal beliefs, and 1 was due to an alternative plan for vaccination. Since then, California has removed personal and religious belief exemptions. Only health-related exemptions are allowed now. But unfortunately, we are seeing cases of measles crop up elsewhere in the United States. For example, there are pockets in New York State, particularly in certain faith-based faith-based communities that are vaccine hesitant.
And I think, again, this really underscores there is a state by state variability with regard to what is allowed for vaccine exemptions. And so we see that there are certain states that are much more permissive about getting exemptions due to personal or purported religious beliefs. It's been encouraging during the pandemic that many leaders among different faith-based communities have actually come out in support of vaccination. But we do obviously have to tackle that, a little bit grassroots as well, especially in states that do allow for these personal belief exemptions. I know most clinicians on here do know that there are very few true medical indications that prevent someone from getting most of the currently available vaccines. Even with certain allergies to ingredients, those can be safely administered, particularly in the presence of a clinical allergist. So really addressing a lot of these personal or philosophical beliefs, many of which are often fueled by misinformation or misleading claims, is really going to improve global uptake and reducing vaccine hesitancy.
So unfortunately, we are seeing, increased hesitation for routine vaccinations, and it feels like we're undoing decades of really fantastic progress for public health and preventive medicine. Unfortunately, children will die preventable deaths, but of course, it doesn't have to be this way. And our goal through Unbiased Science, and of course, your goal, since you're here today, we know that we're all passionate about educating people about vaccines effectiveness and the disease risk, with the shared goal of increasing vaccination uptake. So we want to now sort of hone in on themes in vaccine hesitancy, because understanding why people are vaccine hesitant, of course, can help us structure the way that we educate the public. So for sure, the number one reason that we've seen for hesitancy to vaccinate is fear of ingredients and this general chemophobia that we see on the rise in the public. And sorry.
I was going to say, chemophobia is obviously not unique to vaccines. This is a trend that we see kind of across the wellness industry at large. But of course, and this applies to, our agriculture, our food supply, beauty, skincare products, but of course, the ingredient list, and we see a lot of this misinformation shared about the product inserts. And again, this is not a new topic. This is not a new, argument against getting vaccinated, but it did accelerate because many of the COVID-19 vaccines were utilizing a newer vaccine technology, utilizing an mRNA transcript to elicit our own body's production of the antigen of interest, the spike protein, which is in contrast to some of the older technologies using things like inactivated virus, which is an intact virus that's typically inactivated using chemicals such as formaldehyde, or a protein-based subunit vaccine, which is kind of the next step beyond an mRNA transcript, which is the physical protein that you're simply injecting. So a lot of the work that we did at the podcast and broadly was addressing what are the ingredients. They're not as scary as they sound. Let's address some of these chemophobic trends. Just because you can't pronounce a chemical name doesn't mean that it's inherently harmful. In fact, a lot of these names have a very distinct reason and nomenclature for why they are named, and ultimately trying to educate the public and of course clinicians why those substances are in a given vaccine formulation. Is it a stabilizer? Is it part of the active ingredient? Is it, ensuring transport? Is it an emulsifier? So all of these things to really underscore what they are and why they're in there.
And I just want to clarify, these are actual screenshots of infographics that we've developed and that we share on our social media channels. And then, of course, we also have the podcast that allows us to do deeper dives on these things. But some of this content, as you could see, it's a little bit more technical than what we would typically put out for the general public. And our goal with posts like this is, as Andrea just said, to educate clinicians, and then clinicians can then take that information and share it with their patients, because it means a lot more coming from clinicians than it does, from random scientists on the internet. But as Andrea said, I think, our goal is to demystify a lot of these things and really just let people know that, what's in these vaccines. It's actually quite simple, right? Lipids and salts and sugars and all these other things. And so again, our goal with this is to demystify, be very transparent about what the ingredients are and the purpose that they serve. We also address some common questions. There are lots of questions about allergies. And of course, early on, there was a very big concern about, will the vaccines alter DNA? So we address all of those questions head on. We also let folks know that vaccine components only remain in our body for a very short period of time. Vaccine ingredients are cleared quickly from our body after injection. As Andrea said, these antigen-presenting cells process spike proteins and initiate the development of memory immunity. And then after the mRNA is used to make those spike proteins, it rapidly degrades, and then the proteins follow shortly after. But really, this is a part, as Andrea said, of this larger theme of chemophobia that is going on, in society now, and it's really accelerating due to social media. So a lot of what we're doing is responding to myths that have sort of gone viral about how the vaccines they don't contain these ingredients that are listed here: fetal tissue, gluten, mercury, aluminum, microchips, so on and so forth.
And a lot
so
of
we're
this,
addressing
of course,
those things head on.
A lot of this is, of course, born out of intentional disinformation being spread by certain high profile individuals that not unique to COVID, but certainly have been very vocal proponents or opposition to vaccines. And of course, with the COVID-19 pandemic, with all eyes on vaccines in that very moment of time, the environment was just kind of ripe for a lot of these myths to spread again.
And we don't present it here. We have tons of content on this topic, but we also spend a great deal of time talking about the very rigorous testing that goes on, the multiple phases and trials in clinical testing. So we're really underscoring the safety testing process. I'll turn it over to Andrea now.
Sure. Yeah. So another theme that we see, and again, not unique to COVID-19, but something that we see quite a bit across all vaccinations, is the opposition to government control in particular, and then mandates. So this is something that, we heard a lot about with regard to COVID, and even things like masking. But this is something that has been true throughout history of vaccinations. So just for some examples, vaccine mandates, and we really try to set the stage with a historical context, is that mandates are not new. Mandates have existed since the early 1900s, particularly with regard to smallpox outbreaks. And so there was a very pivotal outbreak in Boston in the early 1900s, where you can see the case fatality rate of those that were unvaccinated was substantially higher than those that were vaccinated. And at that juncture, the Boston Department of Health implemented a vaccine mandate for everyone to get smallpox vaccine. This was, of course, challenged by someone, Henning Jacobson, who actually sued the state of Massachusetts. He was fined a monetary fine for refusing to get vaccinated. But even at that juncture in our early history, the Supreme Court held that vaccine mandates are constitutional. Now, this is the statement was basically, while you can't force an individual, you can't force a mandate to protect just one person, you can implement mandates to protect the population at large, which is the goal of vaccine requirements. So Currently, we have a variety of vaccination requirements, both for children and for adults. But as I noted earlier, this does vary state to state. There really are no federal mandates, with one exception, which we'll get into in just a moment. So for most states, there are vaccine requirements for things like public schools or daycares. However, there are states that have very loose personal or religious exemptions. And then there are some states that only allow legitimate medical exemptions. In addition, all states plus DC require vaccines against diphtheria, tetanus, pertussis, polio, measles, rubella, and chickenpox. In addition, the majority of states require teens or preteens to get the meningococcal vaccine. We know bacterial meningitis can be a very quick onset disease and can be quite serious and fatal in a very short period of time. And there are 4 states in the US that require HPV vaccination, which is great to see this progress. But more can be done with regard to HPV. Now, even on the side of adult vaccination requirements, there are different state by state regulations. So for example, New York State has healthcare workers, hospital workers, nursing home workers, they all have to have MMR. Rhode Island requires childcare workers to be vaccinated and also have annual flu shot. And there are certain states that have college vaccination requirements as well. And of course, it's really important for people to understand that mandates literally are the reason this country exists. So in 1777, George Washington ordered his troops coming through Philadelphia and Valley Forge in the winter to get vaccinated or at that point inoculated against smallpox. And that vaccination campaign is often thought to be why the Continental Army survived and was able to win the Revolutionary War. In contrast, Benedict Arnold, along with John Adams, who actually were trying to invade Canada, they forbade inoculation, and the troops either fled at the end of their commission or they were too sick to fight because there was a smallpox outbreak. And some actually tried to self-inoculate without a doctor's supervision. And unfortunately, they didn't realize that they needed to quarantine because that was a live smallpox virus. And ultimately, that group of troops was not able to fend itself off. And it's thought often why Canada doesn't belong to the US now. Now, even after that, vaccines were implemented for all military personnel, including all of those listed following World War I and World War II. And beyond that, we have US military vaccine mandates for every branch of the military. There are 17 different vaccines that are required by the Department of Defense, depending on where individuals are stationed. It has all of the standard vaccines, but it also includes certain other kind of tropical diseases, things like anthrax or botulism, campylobacter, rabies, also often requires prophylactic treatments for things that don't have vaccines like malaria. And so it's really important to underscore to the general public that, this isn't about forcing you to do something. It's about protecting the community at large.
So another reason why folks are vaccine hesitant is that they lack awareness. They don't have knowledge, whether it be gaps in knowledge about vaccine effectiveness or eligibility. So a great example of this is anytime that we put out information about the HPV vaccine, many people don't realize that the vaccine is recommended for both boys and girls, both. And there are also questions about age limits. So yes, the HPV vaccine, as we know, is recommended for everyone through age 26, but it is also available through age 45. And this came as news to the majority of people who follow us. There are also questions about whether you should get the vaccine if you're in a monogamous relationship. People are not aware that there are many different strains of HPV and that the vaccine is recommended even if you've previously had HPV or if you are in a monogamous relationship. Unfortunately, we are also victims of our own success. So many people really don't fully grasp the impact of vaccines and the impact that they've had on reducing morbidity and mortality, because so many of these diseases really, they don't exist now. And so we're often reminding people of these things. Polio was eliminated in the US through vaccination. Smallpox was eliminated. Rubella was eliminated, all due to mass vaccination vaccination. And then we let people know it only takes one person, one traveler, for example, with rubella or polio to bring these diseases into the US, and that could put us at risk for losing our eliminated status. We often remind people of the impact that vaccines have had, over time. So over 1 billion children have been vaccinated over the last decade, and it's estimated that 4 to 5 million deaths are prevented per year due to these vaccines. Let's see, what else do we want to highlight? I'm just trying to be cognizant of time here. The measles vaccine, for example, has prevented 25.5 million deaths since 2000. We also show people historical photos. We let them know what the grim reality of iron lungs were at the height of the polio epidemic. We're not scared of polio because most people who are here today, they haven't experienced this. So they don't really understand what reality could be like without vaccines. So again, I mean, we have so much content on this, on the impact of vaccines. I'm just going to go through this. Let's see. So we'll highlight, so using rubella as an example, it infected 12.5 million Americans, caused 11,000 miscarriages, and killed 2,000 babies. And as a result of mass vaccination, rubella has been eliminated in the US since 2000, with a handful of cases reported to the CDC since 2012. Just in the interest of time, I'm going to gloss over some of this, but then we'll also give examples of what happens when we regress and when we see low vaccine uptake when there was previously high vaccine uptake. So for example, in Japan in 1974, there was a large outbreak of whooping cough, and 80% of the country's children received the vaccine. That year, they had only 393 cases of whooping cough and 0 deaths associated with both the vaccine and the disease. But then, unfortunately, vaccine misinformation spread, vaccine rates decreased to only about 10%. And lo and behold, we saw another major pertussis epidemic with more than 13,000 cases of whooping cough and 41 deaths. And there are so many examples that we could show, but I think I'd love to turn it over to Andrea.
Let's quickly go through the last two kind of reasons for hesitation. And so the first is, of course, natural immunity is going to provide me protection, so I don't need to get vaccinated. And so this obviously goes down to the appeal to nature fallacy, the notion that things that are natural or derived from nature are superior to things that are synthetic or manufactured in the lab. And so, of course, we try to underscore, the benefits of vaccine-induced immunity compared to infection-associated immunity. So obviously, yes, in some instances, natural immunity can provide protection, but it comes with a lot of risks depending on the illness that you're talking about. And in some instances, it doesn't provide long-term immunity or protection against future illness. So a lot of that messaging goes back to the notion that, there are risks, there are benefits to vaccine-induced immunity, regardless of which vaccine you're talking about. We often talk about long-term benefits, particularly for things like HPV, which can prevent cancer as well. And also talking about the safety and the efficacy of the testing and the manufacturing process of vaccines. We often see this appeal to nature fallacy go hand in hand with the chemophobia as well. And of course, we talk more broadly about the appeal to nature fallacy, beyond just pathogens, but also chemicals and toxins that are produced by pathogens and things like that. Simply just because something exists in nature doesn't mean it's inherently good or inherently bad. It simply is what it is. And I think the last one, which we kind of talked about as well, is the autism claim. So, of course, this started with Andrew Wakefield during the late 1990s when he published his study in The Lancet, where he was claiming that there was, emergence of autism or autism-related symptoms with the currently available MMR vaccine. So we've debunked this ad nauseum on the podcast infographics, but also on the episodes. And I'm sure everyone is familiar with the history here, but ultimately there was no evidence. Those studies were retracted. He was trying to sell his own vaccine and his at-home gut diagnostic test to make money. He did, his license was revoked and he now lives in Texas, continuing, unfortunately, to share misinformation. But this thing keeps recurring beyond just MMR and also through other vaccines. So this all really goes down to online vaccine misinformation and disinformation, because in a digital era, these myths and these misconceptions spread much more quickly. Indeed, false claims spread at least 6 times more quickly than credible information. And there's a lot of psychology behind why that is. But these are sort of the toolkits that we like to equip people when they're seeing something online. So 5-point checklist, ask yourself these questions if you see something shared online and it sounds maybe scary or suspicious. See, does this person have relevant expertise? Are they making statements that are contradicting all of the other relevant experts in the field? Are they promoting something that's a quick fix or a too good to be true? Or are they using anecdotes to support their statements? And often those can be really easy red flags to identify and start to suss out what is misinformation and what might be credible. So of course, we also talk a lot about who is most susceptible. And this really goes back to a lot of those underlying reasons for why we see disparities in vaccine uptake. So education levels, distrust of the medical community, if people are more inclined to have positive attitudes towards alternative remedies. So this could be philosophical and cultural, as well as belief in one type of health misinformation that kind of feeds other sorts of health misinformation. So if someone has maybe fallen prey to the, we're hiding the cure for cancer misinformation, they may also fall prey to, pharmaceutical companies are trying to con you by getting you vaccinated. So we actually do create these actionable items, these steps where we want to equip people to actually address misinformation. And some of these are very similar to the recent HHS toolkit that was published that gives, the everyday person some options to address loved ones in their lives on how to, determine whether or not this may be credible or not.
And a lot of these recommendations come from the 2021 U.S. Surgeon General Advisory document, but there are things like avoid judgment, listen to concerns with empathy, establish common ground, suggest other explanations for what's being put forth, stay calm, try not to get too heated about things, and then maybe spread the topic over multiple conversations rather than hitting people with a ton of information at one time. Okay.
So this is really just an expansion of that, because
Yep.
there are some people who have fallen prey to misinformation, and some are going to be receptive and some maybe not. We've seen kind of certain people dig their heels in and be completely, resistant to acknowledging reality. But there are some individuals that many healthcare providers are going to deal with. Can you just go back a slide?
Oh, sure. Sorry.
Who have legitimate concerns. And I think, some of the earlier presenters actually talked about this, but being able to actually have a trusted conversation, providing credible evidence, but also a bit of an emotional appeal. Now, we know emotions are not data, but when you're having these person-to-person interactions, emotions can be very impactful. So if you personally were vaccinated, share those reasons why you did it. Why do you trust the vaccine development process?
Sorry, Andrea. I'm getting a little trigger happy with the clicker.
Go ahead.
Okay, so we rely, through Unbiased Science on the power of social media. We call it a double-edged sword because it's, really fantastic for pushing out credible information, but it's also unfortunately being used to spread misinformation. But we do know that this is where a lot of people, and in particular parents, turn to social media and online forums for information, especially regarding health and science-related matters. And I think, we're sort of repeating a lot of common themes here. We just want to be cognizant of times, but really presenting information in a factual way, leaving your opinions and emotions at the door, which can, of course, sometimes be difficult to do, avoiding technical jargon, technical details, to talk about things like the severity of symptoms and illness, as well as duration, rather than just overwhelming people with technical details about vaccines, which might be too much for them to digest.
And I want to just expand on that. So like we've seen on Twitter in particular, a lot of scientists or clinicians with regard to kind of the details, they get really granular. They're almost having like a journal club online, which is really not the best forum when that's a public forum. And so what ends up happening is that little bits and pieces of some data from a given study are co-opted by those who have an anti-vaccine agenda, or even media outlets who maybe don't fully understand the scope of what that study is saying. And that's what gets grabbed onto and reshared. So it's both intentional, but even unintentional. And so I think we always want to keep in mind who is our audience and what purpose is what I'm saying serving. If this is simply, you're trying to stroke your ego by sharing something that you interpreted, differently than someone else, that might not be best suited for a public forum. That might be best suited for a conference among your peers or a seminar series. But we have to keep in mind that the public has all eyes on healthcare providers and scientists in this moment.
And it's really interesting, now that we have unbiased science, where we're very keenly aware that it's not just what we're saying, it's how we're saying it, how we're framing information. And so we found that using a presumptive format to initiate this conversation is actually often better. So if, for example, framing the vaccine as the default option and normative behavior. So saying things like your child is due for their vaccine, as opposed to, are you planning on getting your child vaccinated against this flu, the flu this year? Things like that actually can make a difference. And many of you as clinicians, I'm sure you all realize the impact that what you're saying has on your patients. And I think we know that sharing your own vaccine decision-making process and really personalizing recommendations can make a big difference, that establishes the connection and trust between the parent and provider. So the bottom line that we want to convey is that it seems like we're fighting an uphill battle, and we know that we are, but improving vaccine uptake is possible. And we wanted to share, as we close out here, just a brief case study. So we actually rolled out an influenza vaccine education campaign, and we did lots of things. It was very involved. We did surveys, we did focus groups, we had key informant interviews, and it basically led us to develop this education campaign. It consisted of Instagram events, live events, infographics. We did podcast episodes. And then we assessed the impact of the campaign. And we found that over 1.3 million people viewed our flu vaccine education campaign on Instagram and Facebook. We estimated that 336,000 viewers were involved in patient care. Over 200,000 were doctors, nurses, PAs, or pharmacists. Of the 1.3 million people that we reached, between 66,000 and 215,000 did not plan to be vaccinated against the flu this past flu season. And based on our survey, we estimate that we changed about 15% of respondents' minds. 12% were ultimately vaccinated, and 8% attributed their decision to vaccinate to our campaign. This means that between 5,400 and 17,500 people were vaccinated in response to our education campaign. And just anecdotally, in the focus groups that we did, 100% of respondents changed their mind and said that they were more likely to vaccinate once we presented information in this, very direct manner. So we can affect change. And of course, we have to work together to ensure that decades of public health progress are not undone. Andrea, do you want to close us out?
Yeah, so I'll try not to use the closing that I always use on the podcast, but we really thank everyone. We were honored to have this opportunity to discuss with you our approach as scientists and how we try and tackle misinformation on a lot of topics, but specifically immunizations. We are very active on all social channels. We do have a website, which includes a searchable keyword database if you're looking for content. And then we do have our podcast on all streaming platforms as well as on YouTube. So we we really thank everyone for their time. I see there's a couple of questions in the chat box. I'm going to try and type some answers, but we can also take some verbal questions with the time we have left.
Thank you so much, Dr. Love and Dr. Stair, for a wonderful presentation. I know that you got a head start on the questions, Dr. Love. So, but in the meantime, I could just continue to read them. If a person, child or adult, migrating to the US has all doses of polio vaccine, but receive OPV, should that person receive an IPV dose?
Oh, that's a good question. So from my understanding, and actually I recently got my own childhood vaccine records. I had 4 doses of the OPV. I believe if you've fully completed the OPV series, especially since that's, there's a period of time with which you will no longer be shedding potential vaccine polio in your stool, then there should be no clinical reason to then subsequently get an IPV dose. I believe the recommendation is if you have not completed the OPV series, they may have a follow-up IPV vaccine dose.
Great, thank you. Thank you for a wonderful presentation. Any advice or data on how to address or convince parents of kids under 5 to get primary series of COVID vaccine for their kids, especially since many of them already had mild disease prior to when the vaccine was approved, and now COVID cases are low?
Yeah, so this is a really tough question, and it's something that we get a lot. And I'll maybe chime in quickly, and then I'll let Jess maybe have a stab because she does also have young children. So the biggest thing is we always want to underscore that, yes, broadly speaking, on a population level, COVID is milder amongst children than certain populations of adults. However, that does not mean it's always mild. We always like to underscore that there have been several hundred deaths among young children due to COVID, and most of those are amongst unvaccinated children. In addition, most of those are also among children with underlying conditions. But those underlying conditions are not always immediately apparent because they're a child, right? It hasn't certain diagnostic tests may not reveal some of these underlying issues. So it's important to always note that just because someone may appear healthy from the outside, it does not necessarily mean they're completely immune from having severe illness. Another thing we also like to underscore is if your child is personally low risk, what about the people they encounter? So yes, we know that the vaccination does not prevent all cases of COVID or all infections, but we know that the higher the levels of neutralizing antibodies, the lower the likelihood is that you personally will get infected and can then transmit it to somebody. So if your child is low risk, do they have any friends that maybe are higher risk? Do you live with individuals or adults in your household that are maybe higher risk? Maybe you as the parent work with individuals who are higher risk, and you don't necessarily know off the top who might be high risk, right? Immunocompromised individuals, it's not always obvious, right? So it's one of those situations where you want to underscore the risks to them personally, but also the risk to your community at large, because that's really what the goal is of vaccination. It's for individual and community protection.
And the one thing I'll add, I mean, Andrea said it all, but yes, I do have 2 young children. My children have both received their primary series as well as their booster dose. First of all, as a parent, you never want to see your child sick, and it's a very basic cost benefit, risk benefit analysis. The risk of the vaccine is so exceedingly low. Adverse events are so rare, and the benefit is, far outweighs the risks. And any single child hospitalization or death is too many. And so if we have a safe tool to prevent even a single child hospitalization or death, to me, it's, the choice is obvious.
Thank you, Dr. Stair. So we have one minute left, but I'll try to get through 1 or 2 questions. Do you have more information to share about your flu campaign? Sounds fantastic.
Oh, yeah, sure. So we did a survey. The first thing we did was we really wanted to assess which pockets of the population were flu vaccine hesitant. And then we wanted to understand their reasons for vaccine hesitancy. And what we found out is there were really 2 populations that emerged as being the most hesitant. One was African Americans across age group, and the next was white men living in rural communities, particularly in the South. And the reasons for hesitancy were different, but we really tailored the campaign to those concerns. So one, there was a total lack of awareness of the availability, for example, of nasal vaccines, the spray vaccines. There's a lot of needle phobia, particularly in the African-American population, we noticed, and just a fear of injections, this general mistrust of science in the medical establishment. So a lot of what we pushed out was really underscoring the way that, flu vaccines are developed, their testing, their safety. There was a lot of hesitancy about, the effectiveness of flu vaccines, understanding that influenza mutates. So how is it that, that we have a flu vaccine every year, and how is it updated? So we talk about things like antigenic drift, and the ways that flu vaccines are updated on an annual basis to target specific strains. People just weren't aware of these things. And so we pushed out a lot of different information and a lot of different modalities, different levels of technicality, and it proved to be highly effective. We partnered with other pediatricians. That was very effective because we know that clinicians really, there's a lot more impact that clinicians can have, as I said, unfortunately, as compared to scientists like us. So partnering with clinicians was very impactful. But yeah, just having that conversation, we learned in focus groups, they said they had never had anyone break down the information in a simple way for them. And just that was really effective at changing their perspective. Sorry if that was rambling.
Okay, thank you so much. That was great. I noticed that Dr. Love is typing up some answers. So thank you so much for that. So,
yeah, absolutely.
Okay, great. So now we're going to turn it over to our Immunizing Our Communities panelists. Thank you again, Dr. Stair. Thank you again.
Thanks, everyone.
Thank you.
So now up we have Dr. Rachel Evans, our Chief Medical Officer from the Henry J. Austin Health Center, Micah Freeman, Supervisor of Nurses from the Trenton Public School District. And then we'll have Margie Yon from the Health Officer, from the Freehold Health Department. So as they're preparing their slides, Dr. Evans and Micah Freeman, I'm going to introduce Dr. Evans briefly. Dr. Evans took on the position of Chief Medical Officer at Henry J. Austin Health Center in 2007. Since 2012, has provided direct care in the Women's Health General Medicine and Pediatric Department at the Health Center. She has a strong interest in women's health and addiction medicine, and spearheaded the Henry J. Austin Health Center Medication Assisted Treatment Program. Dr. Evans, please take it away.
Can you hear me okay?
Yes, I can hear you.
Okay, great. Thank you so much. Good afternoon, everybody. This has been so great. Thank you. And I also wanted to answer a lot of those questions on the last chat because they come up so often in our patients, as well as we talk about hesitancy and how do you catch up kids, et cetera, et cetera. But thank you. That was marvelous. And so happy to be here. And Micah, do you want to introduce yourself for a moment?
Hello, everyone. My name is Micah Freeman. Thank you for having me. I'm the nursing supervisor for Trenton Public Schools. I want to give a shout out to our school nurses who are on the call. I appreciate you being here.
Thank you. And do you want me to share the slides as we go?
Yeah.
Great. I'm going to go ahead and start sharing, and then I will not be able to see everybody necessarily when I'm sharing my slides. I can only see some of you, so definitely just holler or jump in if you have a question. So here we are, and this was really, we're here to discuss just our experience of the power of partnership and how working together, our federally qualified health center and the Trenton Public Schools and the Trenton Public Schools Office of School Health were able to really make a significant improvement in vaccination rates in the Trenton Public Schools. And I'll start off by saying that Mike and I have been fortunate to collaborate for years, but we've really found ourselves in the past sort of doing the same things with the same outcome, which was not great. And you'll see when we start to talk about what this past year looked like, we really found ourselves in an unprecedented situation in terms of that vaccine need, and really needed to come up with innovative solutions to try to meet that need. So I'll just sort of highlight here the problem we had on Beyond Our Usual Problems. We're starting into this past calendar year. We had a high number of Trenton Public School students that were at risk of exclusion from school due to under-vaccination. So Mike, as a supervisor of nursing, her nurses all work really hard to track all that, and they had 1,297 students who were behind on vaccinations, who were at danger of being excluded. And we'll talk about our individual organizations in a moment, but the Trenton Public Schools have about 15,000 students overall. A lot of this had to do with, of course, we know that there is a decrease over the pandemic in terms of general preventive care and vaccinations in particular. In the Trenton community, we'd seen a very significant influx of new families in the community, many of them from other countries. And so I'm just sharing a little bit here about the Trenton demographics in general. If you look at kids under 18 by race, the green is from 2011 to 2015. The blue polka dot is from 2016 to 2020. And you can see that in that time, we saw a flip of our demographic, so that early on, we had a majority of children identifying as Black or African American. And then now from 2016 to 2020, we saw a majority identifying as Hispanic or Latinx, and that continued to grow. So this is 2020 data that has continued to grow over the past few years. And then in the Trenton City, we have limited pediatric primary care options. And we also have an interesting relationship where the city public health department has, of course, been very engaged with vaccinations. In Trenton, the city public health department partners with Henry J. Austin to provide a lot of these basic public care things, public health care things like pediatric vaccines. And we'll talk about some of the challenges with that. I think many of you are aware that during the pandemic, the state really provided a lot of support for FQHCs to vaccinate outside of their own patient population. So really trying to meet that community-wide need. But there are a lot of challenges and barriers to making that happen seamlessly. And we'll talk about that a little bit more. So that's where we were at the beginning of this calendar year. And I think some of our strengths heading into that, where we already had these very strong relationship between the Trenton Public Schools, Henry J. Austin Health Center as a federally qualified health center, the state, and then the Municipal Department of Health in Trenton. We've had a lot of experience in this shared collaborative space with vaccine administration, a lot of support from the State Department of Health and from our local Trenton Health team, which is also one of the identified state regional health hubs and works really well in terms of data and creating collaborative community-wide structures, and also sort of advocacy and policy as needed, and then some real boots on the ground community health work outreach in terms of vaccine hesitancy. And then hopefully both the Trenton Public Schools and Henry J. Austin were already seen as trusted resources by parents and the community. So when we tried to reach out, we were really hopefully seen in that space of being trusted resources. And I appreciate the distinction about medical providers or school staff and scientists, although I have to tell you that during the pandemic, we really also found a significant shift in our patients and how receptive to vaccine information they are, even in the healthcare setting. I don't know, Micah, if you want to speak just a little bit about Trenton Public Schools and some of the strengths that your team brought to the table here.
Certainly. I hope everyone can hear me. I hear a lawnmower going off in the background, so I hope that do not interfere with what I'm saying. But overall, you know, with our school nurses, we played a very active role in identifying the students who needed immunizations and physicals, because there were, we have a lot of students who are from out of country or out of state. And at the time, before the New Jersey Family Care extended their efforts in insurance, you know, we had some struggles with students getting what they needed. So with that, partnering and Dr. Evans, you know, hands down, Henry J. Austin was awesome in providing care to our students. So one of the things that we didn't want to do, we did not want to exclude students from school. We identified over 1,297 students, December 2022. Once we found out we had to figure out how can we keep these kids in school. It was towards the right before Christmas break, and that's when we reached out to the state. We reached out to Henry J. and some other partners to see how can we help our students. So we had students with insurance, we had students without insurance at that time. And then once in January, when they expanded it to everyone, that became more resources. We just collaborated. We again, a lot of emails, a lot of text messages, a lot of outreach. Other than going door to door, we really did nail down some services for our students, in particular, their childhood immunizations, right? They're mandated. And I appreciate all the presenters before for just laying the foundation of why we are doing what we're doing. And in addition, I want to say this, that the New Jersey Department of Health in November 2022, they provided importance of catching up childhood vaccinations. So this is right on the same timeline as our efforts. And that's how it leveraged and helped our school district to really see the importance of working with the nurses, working with our providers to see the importance of this. So again, I want to acknowledge our school administrators for putting helping us in this charge. I want to acknowledge our principals, our parents. Our parents were very again, it's about building good relationships. No one wants their child out of school. And when you have a good relationship with your school staff, your school nurse, different people that you see every day, your teachers, when everyone is on the same page, it helps to make appointments, it helps to get these students vaccinated. So with that, we were able to provide appointments over the Christmas break. Thankfully, Henry J. Austin was able to extend their hours weekends, and I know that it was time. It was it was a lot. It was a lot, but we were able to get from almost 1,300 students to 150 students who are now non-compliant. Now, unfortunately, again, we did not want our students not to be in school. There's a lot of kids, to not have in school, even though that is a public health issue. There were some things that they could not do. They could not go on field trips. They could not participate in sports. We had other strategies that we had to put in place. And again, I appreciate everyone who helped out in this effort. Dr. Evans?
Thank you. Thank you so much, Micah. And I just want to make sure, can everybody see the slides now? I'd seen some conversation in the chat about how maybe the slides, can everybody see my screen share?
Okay.
Hopefully someone will jump in if I need to do something different. So just to kind of expand on what Micah had said. So in addition to all those great school-based resources and support, Henry J. Austin Health Center as an FQHC has various different resources to support vaccination. So we have some federal funding for that. We had a lot of support from the State Department of Health, and we had municipal support, and our relationship with the Trenton Department of Health has been very important. We also had already launched on a HRSA-funded school-based services initiative. And I think that was one of the key factors in our success, because we already had those relationships with the school administrators, with the school nurses. We were already inside the schools. And so you have to picture that when we talk about strategies that worked, instead of trying to bring students to our health center and their parents, we were able to engage the students in the health center, and really want to highlight the role of technology. So a lot of these kids, their parents were not English speaking, primarily Spanish speaking only. A lot of them came from other countries under really difficult circumstances and maybe did not have their vaccine record and had to start all over again. So that question of how many shots is too many, we give a lot of shots in one sitting when we're trying to catch up a teenager who is behind on all their vaccines, and they do fine. But then also you just have to picture, so we did these in the school. So we brought our nursing team, our providers as needed to the schools. The administration was kind enough to open up the schools to us and really provide that support. And we can talk a little more about the logistics of vaccine transfers and billing and coding, but we have a mobile health unit for community-based vaccination initiatives, and that also is really helpful. And then the parents and kids themselves were very engaged. And a lot of it, as Micah says, is those pre-existing relationships. The parents trust the school. They get this whole communication network of text blasts and flyers. And so as we told them, you can get these services done at these locations, they came. And it really became clear that it was a question of communication and that it was a question of making access available. And once we did those two things, the students showed up. And the kids themselves played a strong role. So there were so many kind of middle school kids you have to picture doing the work themselves, showing up for these visits, getting their parents on the phone, sending text pictures of their own vaccine records. I really want to give a little shout out to the kids because they were very engaged in all of this. And it was really, they wanted to go to school, they wanted to be present. And so I think that was really helpful as well. What you see pictured here is some of our school-based team and having those bilingual community health workers working hand in hand with the parent liaison. So data is always a challenge. The school understandably has to be very protective of their data. In our case, again, fortunately, the school already had that existing relationship with the city, and so did we. And we already had those MOUs in place that allowed us to share information. So our community health workers could work hand in hand with those school nurses and with the parent liaisons to outreach families to try to work through those lists of kids who are missing vaccinations. And then just as Micah said about the school administration, we were lucky at Henry J. Austin to have the leadership of our board of directors really supporting us to go on beyond our usual role as a health center. So it bears repeating for those of you who work in health center environments. Our usual mandate is our patients, and that's usually how we're staffed. That's how we're funded. Anytime that ask is, okay, now let's go beyond and look at someone who is not a HRSA designated patient at your center, you have to think about what does that reimbursement look like? What does that data look like? What do I do now that they're in my patient space, but they're not really going to be my patient? How do I avoid disrupting relationships with other primary care providers? How do we meet the need when, as you can see from our slides, Trenton Public Schools has 15,000 kids, Henry J. Austin has 18,000 patients. Obviously, we can't vaccinate every single one of those kids, but we want to try to prioritize those that truly need our services. So then just to kind of highlight a few more of the challenges. So we talked about those new students, and Micah had shared this data that the beginning of the year, we had that many students. Then in March, we saw a huge influx, up to 40 new students per week per school, the vast majority Spanish speaking from other countries, questionable vaccine records, et cetera. That's a huge need and a big pressure on our existing structures. I've already spoken a little bit about how as an FQHC at this moment in time, we get a lot of pressure and mandates from HRSA to say, now it's time to catch up all your adults on colon cancer screenings, pap smears, breast cancer screenings. We can't really afford to pull resources to focus on every child in the community who might need a vaccine outside our patient population, but we also needed to, so we worked on that. And then, as everybody knows, there's a nationwide nursing shortage, and we mostly need nurses to give vaccines, and that's a challenge. Our school districts suffer from that nursing shortage, just as our health centers suffer from that nursing shortage. So I can't say enough about our nursing team and the school and Micah's nursing teams and just how hard they worked and how committed they are. When we talk about some of those barriers, actually for our initiative, there were some parents who were vaccine hesitant, but really most of it was language and cultural barriers, challenges with healthcare access, fear or lack of understanding of those publicly funded resources, and then just lack of access. During the times that parents could come, what we found is that when we opened up to evenings and weekends, parents came. They weren't so much hesitant as just unaware and unable to come during the school day. And then finally, we could spend the whole time talking about the vaccination funding and where it comes from, but it is a very complicated network. And just to kind of highlight some of that, and many of you have been part of these conversations, as an FQHC, our Vaccines for Children PIN number is administered differently than the Department of Health PIN number. And how we do our inventory is structured around primary care. And so saying we're going to suddenly double, triple, quadruple the volume of pediatric vaccines we're providing is a big inventory management challenge. And then there are all the compliance pieces that go along with that. So my director of nursing and my vaccine manager had to make sure that every time we brought vaccines to a new location, that we were following our inventory protocols, making sure that we were tracking the temperatures all along the way, making sure that everything when we were audited by the state VFC program was going to be in line to show that we were managing our vaccines in a way that was appropriate and compliant. We've sort of highlighted some of the strategies that led to our successful outcome, but I want to emphasize what Micah had said. So heading into May, there were only 150 TPS students who are still behind on mandated vaccinations. So that's a real improvement, particularly given that we saw that spike in new students halfway through the spring. And our successes really came from just meeting, talking, making sure we're redirecting everybody's energy, seeing where things go off the rails, planning and replanning, looking at data, looking at more data, making sure that what we're doing is actually working. As Micah highlighted, in New Jersey, we were so lucky to have that Medicaid expansion. So suddenly, instead of trying to provide services for undocumented, uninsured children, we were doing presumptive eligibility. Now, to be clear, that was a big administrative lift. And one of the things we found is that actually it was suddenly our registration team members who are the most in demand, because each new patient who walks in for a vaccine, we're now trying to do the entire presumptive eligibility paperwork with their family, which, as many of you know, is a pretty big lift. These shared communication resources, having these, being able to cooperate and collaborate with websites, email campaigns, texting, word of mouth, community events, that was really key. Walk-in community vaccine events, self-scheduling using our technology. Sometimes we would link a telehealth appointment to a follow-up on a vaccine schedule. Again, for those of you who work in healthcare settings, since the beginning of time, our pediatric and family medicine teams have had this pre-existing notion that to provide vaccines, we have to do a physical. If they're going to be our patient, we have to see them, we have to do a visit, we have to make sure we've assessed them and then do those vaccines. For us, it was really a shift to say, actually, the need is vaccines. And yes, we would like to engage them in primary care, but if we're being really straightforward, many of these students will not come to us for primary care because we don't have the capacity for them, and hopefully they will have a primary care home elsewhere, but that vaccine need is what is needed right now. So how do we prioritize that and remove any barriers? And then we did vaccine events at the schools, at community events, at our own locations, evenings, weekends, just really expanding that staffing. And one of the things that really helped with that was grant funding from the state that was supporting vaccination events. So I highlight that just to say it was necessary, it was helpful. It's also not a long-term sustainable source of funding. So I think that's one of the open questions as we finish up, is just thinking about how do we continue to support this going forward, just recognizing that as a health center partnered with the schools, we are still providing services reimbursably in that structure of visits, and that requires licensing and paperwork and all those other pieces that make it a little more difficult to make something sustainable.
And I just want to add to Dr. Evans, the key is partnership, collaboration. For example, we are having centralized registration coming up June 5th. We are hosting New Jersey Family Care. They're going to have some pop-up sign-ups. So as students are registering their kids to school, we're going to have insurance company right there to help them sign up for New Jersey Family Care. In addition, we're going to have Henry J. Austin right there to assist with if they need a physical, if they need immunizations, to assist with that. So we cannot do this alone as a school district. We need the community. So my goal is to just reach out to those who can help us to help our students and our families. Thank you.
So
Any questions?
Dr. Evans and Micah, thank you so much for sharing your story and the wonderful work you've been doing in Trenton. Micah, I apologize. I didn't get a chance to introduce you. I'm going to send I'm just putting your information in the oops, sorry. got excited because I want to share your
that's
information.
good.
So I put it in the chat, but I also shared all of the presenters' bios because, you know, I can only share but so much information. So, you know, please take the time to read those bios when you get a chance. But thank you again for your wonderful presentation. So I do have a few questions before we move on to our next presenter. So why do you think State Department of Health official has not made it mandatory for private pediatricians? Hold one second. Okay, yeah.
I can speak to that one a little bit,
Okay.
Kendra, because it's a good one. So why has the state not mandated that private pediatricians have VFC vaccines on hand?
There you go.
I would say that the management of VFC really sort of works the opposite. In order to participate in VFC, you have to be willing to jump through many regulatory hoops. And there are many providers who actually will accept Medicaid who still will not stock VFC vaccines because it is so difficult. And when we talk about this with the state program is clear that they know it's a lift. So they certainly aren't going to mandate anybody keep them on hand because they might just not keep up with that regulatory requirement and then they would lose vaccines. I think the state's perspective, and not to speak, anyone here is a better representative should feel free to jump in, but this is actually a federal program. So the state has to be good stewards of their vaccines from the feds. And so everything that they have is to keep them in compliance with that federal program. So it ends up being one of those very deep bureaucratic things that we encounter all the time in public health, where it's sort of built that way and changing it would be very difficult.
Thank you.
Thanks, Rachel. I just wanted to add that we also have like a limited number of money to spend on VFC vaccines. So once the providers or the doses ordered through VFC are full, we can't administer anymore because all the money comes from CDC. So there eventually will become a cap, but we're not near that limit.
Thank you. I think a couple other questions. I did put my contact information in here. There was a question, 2 questions here about audits. So one is, says your success in Trenton is commendable. Do you do school audits more than once a year? How do you follow new students? And then the same question, are there only 150 kids behind or 150 who are eligible during audit time? So Micah, I'll let you speak to that because that's
So, well, thank you for applauding. I'm going to give a shout out to our school nurses because this is a daunting task. 1,200 or 1,297 students. So that each student, their records have to be monitored, and so we do internal audits. Our school nurses, they are the ones who do the internal audits. We get audited by the city of Trenton once a year, and so it's a forever task. With the 150, so remember, we had new students to start. That 150 is also new students. If you're out of state or out of country, you have 30 days to provide immunizations or physical. So I didn't separate. It is actually a lower number than that, but that is with the new students that are that came in February, March, April.
And I will just, there was a question that I answered that I typed the answer to, but it was about staffing. And that's such a great question. We really did a combination of staff that we had hired specifically for outreach events, but mostly we had our same staff work overtime, evenings and weekends. And that is, it's a great strategy. It's a very expensive strategy. And with the level of burnout we're seeing in our staff, that's another piece that really kind of brings us back to that sustainability question. So our hope, we know evenings and weekends are so popular for our patients. Our hope is to continue to hire staff who want to work those hours. And that's just part of this long work we are all doing, I'm sure, of in particular nursing recruitment and retention. And when we talk about that internally with my director of nursing and our HR team, we really think that this nursing shortage is not getting better quickly. We know that that's sort of where the numbers are going, and we really want to continue to retain and support our nurses in the excellent work they do. So we're also looking at some other strategies. We have pharmacy staff who can do vaccines, and trying to utilize those more for our adult population where it's easier. The pediatric vaccines are just the hardest. They're the most complicated. They take a lot of knowledge. And then similarly trying to say, okay, so where do we use medical assistance in some of those situations where we don't need a nurse? And of course, we utilize LPN roles instead of RN roles almost exclusively, just given that cost factor, and doing a lot of things internally to try to support training and advancement of nursing team members, just looking toward the future.
And I just want to give a plug that I'm in the same boat with nursing shortage. You know, we have 2 positions that need to be filled. So if anyone is interested, please go to our website. But yeah, it is a very it was a very daunting task, but it was rewarding, right? From where we were to where we are now. And again, it's all about collaboration. That's how we succeeded in this role.
Great. Well, thank you so much, Dr. Evans. Thank you, Micah, for the wonderful work you've been doing. The community probably this probably wouldn't have been a success without you and all of the hard work you've been doing, you know, over the course of the year and much more. So thank you again. So now we're gonna turn it over to Margie. Margie has slides that she'll be sharing. So as she's getting ready to share her slides, I'll introduce her. So Margaret Yon is an accomplished health officer director of the public health within 32 years of experience in the field. Margie's passion for public health is unmatched, and she has spent her career working to improve the health of the community served by the Freehold Area Health Department, which currently include Freehold Township, Freehold Borough, and Wall Township. She is highly skilled in establishing, maintaining, and leading cross-sector partnerships and collaborations to maximize area resources and services effectively. So Margie, please take it away.
Hi, good afternoon, everybody. I'm going to be sharing you a little bit about how we were able to develop or create a qualified family health center in Freehold, New Jersey. I'm not going to speak necessarily specifically about immunizations. It was really more how we brought the FQHC, but more importantly, also about the work that we did after we created the FQHC and the influence that they can have on childhood immunizations. So just few objectives very quickly. I'm looking to help you understand the role of the public health strategist, which is a relatively new term for public health departments. Learn how the family health center was created or established in Freehold. Understand the evolution of partnerships and the importance of maintaining those relationships, and understanding the need to take care of or to take the next steps after the win. So after we created this federally qualified health center, how important it was to move on. So the Resolve 2014, supported by the Robert Wood Johnson Foundation, convened a group of leaders across the United States to talk about the future of local public health departments as things were changing, and we needed to start thinking about adapting our local health departments to the new times and the new things that were going on. And with that, they created a document, and that document was called the High Achieving Governmental Health Department in 2020 as the Community Health Strategist. So they introduced this Chief Health Strategist term. And why did this organization, this group of leaders, think that we needed to do public health slightly differently? First, our healthcare needs were changing. As you know, chronic disease has skyrocketed. Health departments are struggling with things like asthma and obesity and how to improve the health of the community. Post-Affordable Care Act. So now we know that healthcare and clinical care is much more available. Insurance is available. So the idea that, there's a decrease in local health department services, perhaps as being the fall guy for uninsured, was something that we needed to maybe start thinking about how we respond differently. Information and data revolution. Historically, we would have to wait 3, 4, sometimes even 5 years for data on statistics. Now that data is much more real time, and we're able to get that usually within a year, and sometimes literally live in modern time. The Chief Health Strategist had basically came out with 7 key practices the document did. And I just wanted to focus a little bit on practices 4 and 5 because those are the ones that are technically really related to partnerships and collaboration. So practice 4 is building a more integrated, effective health system through collaboration between clinical care and public health. So what does that mean? Well, that means that we really need to focus, health departments need to focus on close interactive relationships with healthcare providers and with the insurers. Understanding that, we are kind of augmenting some of the work that they're doing, and it's important for us to have a good working relationship to accomplish what we need to do. And we need to know how to connect with those individuals, and we need to know who we need to connect with, right? So who and how do we reach a CEO of a hospital or a provider who that we were looking to want to partner with? And then we also need to know about how to work within the financing network to make it viable. So as a health department or as a health officer, I see, a certain issue that's maybe in a community. How do I go about connecting the dots to make sure that we address those issues? Because I don't have the resources necessarily to do that myself. And so what do health departments do that are differently? Well, we have to expand our health assurance function. So we've always wanted to assure access to healthcare services, but we need to expand that by making more active referrals and physically trying to connect people to resources. And perhaps that means we provide less services. So, right. So it's not necessary for me to give every vaccine, to the uninsured, but there are other providers within my community who can certainly do that. And so it's important for me to link those individuals to those providers, and more importantly, to have the relationship with the providers to make that referral. We need to monitor community access and really, even more importantly, the quality of care. So we may have access to clinical care, but if it's not quality, culturally sensitive, affordable, that's important for us to understand. And then, of course, we have to start thinking about our department doing more complementary services or clinical services, like health education for expecting moms, coming into the homes and doing at-home education, nurses making home calls, and community health workers who are trusted typically within the community to help refer and make connections for residents. Practice 5 is collaborate with a broad array of allies, including those at the neighborhood level and the non-health sectors, to build healthier and more vital communities. So we talk a lot about addressing other things like the social determinants of health that actually, that actually is an issue for people who are struggling with their social determinants, for them to obtain optimum health. So it's a cross-disciplinary collaboration is what local health departments are looking at. It's working with other agencies such as transportation, planning, housing, and emphasizing those partnerships with the other entities so that we can, support and improve social determinants of health. It's supporting leadership within the community, so other community-based organizations and churches and schools, and helping to expand our public health base, right? Everybody wants a healthy community, and it's helping the churches understand their role in addressing some of those social determinants of health to have each and every one of us achieve optimum health. As a public health strategist then, so as an individual leader or leaders within a health department, it's important to have active participation within the coalition. So it's not sending your second in command or your third in command and actually having them participate in the coalition and being a driving partner. Local health departments, we have to provide the needed data for decisions. So if if we're looking at a concern that we have where someone's not sure really that we have a problem with access to healthcare, it's important for us to work to help find that data so that we can help make the right decisions on funding access to care. We have to assist with community planning, and that means going outside, perhaps engaging our planning boards, our local governance to try and make the community itself a more livable and healthier place to live. We share best practices and evidence-based actions, right? That's the information we have. If a school knows that they want to improve, attendance for, I guess Not School is not a good example. If, well, I'll give you an example. In Freehold Borough, their COVID, the money that they're getting for opioid, they wanted to know what they should do with those monies. And so they reached out to the health department to discuss potential avenues, and we share SAMHSA and start talking about best practices and giving them some examples of evidence-based things that they can do with that money to have a positive effect within their community. And we also, it's important for health departments to provide funding and or grants, and that might be through interlocal agreements, but there's a financial responsibility I think that some local health departments can help with. So just to talk a little bit about the Freehold Family Health Center very briefly, how it came to be. It was really a 9-year process from start to finish. And it is something that I am personally very proud that we managed to occur here in Freehold. Just briefly, a little bit of history about the Freehold community. The Freehold community is roughly Freehold Township and Freehold Borough. Just between the two communities, Freehold Township has a population of 36,000, of which 84% are white, 4% are Black, 7.8% are Latino Hispanic, and the median income is about $135,000, and only 3.5% are reported in poverty. Freehold Borough, in comparison, is a smaller population of 12,000, of which 57% are white, 9% are Black, 48% are Latino or Hispanic, and the median income is roughly a half of what Freehold Township is at $62,000 or $63,000, and the poverty is at 17.6%. And interestingly, the childhood poverty at the time that we began looking at the FQHC was at 30% for childhood poverty. So just looking at, this is the town, and the borough is the donut hole in the middle. The problem that we had with Freehold Borough, which is a community of significant need, was that they shared a zip code with 07728 with Freehold Township. So whenever we looked at our health outcomes or demographics, or tried to encourage additional funding at the federal level for an FQHC or at any other level, the Freehold Township numbers would really hide or diminish what the issues were in the middle of the borough. And so it was a challenge to try and bring attention to the borough and the issues that I knew existed in the borough without having the township clog the numbers. And just an example here is the 4 census tracts within the borough, and just showing the percent of uninsured at the time that we began this work. Monmouth County was at roughly 9.6%. And you can see that the 4 communities with the 4 census tracts within the borough were ranging anywhere from 24.5 up to 30-some%. I can't see it. I guess it's 37% almost. So significant difference. And when we, when you look at by comparison to the county. So with the Affordable Care Act, there was a NACHO document that came out that talked about how the partnerships between federally qualified health centers and local health departments were engaging in the development of community-based systems of care. And with the Affordable Care Act increasing funding for clinics around the country, I again looked at that document and began to think, how could we as a health department partner with community providers to try and see if we could have an FQHC in the borough. And there was a HRSA grant that happened to be announced in January of 2011. And it was a health center planning grant. So to allow us to do a needs assessment and to begin planning for a center. And it was roughly for about $80,000. And so I thought, maybe this would be a great opportunity for the health department to apply on behalf of the community. So where do I start, right? Where do we even begin? So I know that VNA Health Group had FQHCs on the east side of Monmouth County and that were successful, and they were interested in expanding their facilities into the western side of Monmouth County, particularly in Freehold. Central State had a family medicine clinic that was in the township that was many people within the borough were unable to get to without transportation. Most people don't have, many people don't have cars or vehicles, and it costs money to get over to Central State. So, and there was often a lot of complaints that their particular facility was not culturally sensitive and was charging a lot of money. New Beginnings and the Paul McGuire Center within Freehold Borough was a voluntary free clinic for with volunteers working. They had very, very limited hours, only a couple of days a week, and provided care for, and they were looking for expansion. And I also reached out to the New Jersey Primary Care Association to teach myself a little bit more about FQHCs and understand the process. In addition, I would have to have the support of the New Jersey Primary Care Association in order to get approval or to as a letter of support for the grant before HRSA would even consider. So I had a partnership meeting and met with these individuals either singly or together. And talked a little bit about the perceived needs, because again, I didn't have the hardcore data in the right way to make an argument for the need for an FQHC. And I had told them that there was a planning grant that I was looking to apply for. I made it very clear what my role was as the health department, that we were looking just to coordinate something here, and that I had no interest in myself in actually doing an FQHC. This was not going to be a health department facility. This was really a facility for the community that I wanted to engage in trying to bring into reality. And of course, there were egos and self-interest. So there were little couple trips, people were a little unhappy that I was actually moving forward. But I think once I made it very clear that this was just my way of helping them move the next step, I convinced it was a simple first step and was able to garner their support. So what happened next? I didn't get the HRSA grant, but I did happen to get a mini grant from the New Jersey Primary Care Association, who did see the need and wanted to explore further potential avenues for improving access to healthcare in Freehold. So they paid for needs assessment and planning activities. We hired a firm to do secondary data. We ran several focus groups. We reconvened the partners in between 2012 and 2013. Interestingly, of course, the focus groups, everything pointed to the direction that this was desperately needed, and that planning should move forward. So as we continued to meet, there were some, I want to say, errant discussions and activities that occurred, because as I had mentioned, there were 3 entities that I approached that were all very interested in becoming their own FQHC. So, there were some, I guess, meetings, and some of those entities kind of took additional steps that were not originally discussed. The Paul McGuire Center had decided they were completely not interested. They wanted to remain voluntary, and as a FQHC, you have to have some sliding form of payment, and they did not want to do that. So they dropped out of the picture, and it really became a conversation between VNA and Central State and the health department. So in 2013, we received additional monies to, again, look at hospital data and start moving the planning forward. We had meetings with the CEO of Central State. VNA at that time had new leadership, and myself, and we met to discuss the potential avenue. Central State was not going to be able to manage or get a, and I guess there was some intervening with speaking with some political venues and the Commissioner of Health at one point in time. Some of that discussion was had between Central State, and the decision really came that the best avenue to follow would be to let VNA be the lead in this particular group. They would go for a change of scope in their services, move the thing on west, and then Central State would provide the physicians and the Rutgers Medical Residency Program, which was currently housed in their family programming. So we had a kickoff meeting in 2014, and then the three groups worked together and applied for a HRSA change of scope grant in 2016. It was successful. We got the grant, went under construction, and we opened a beautiful facility on March 20th, 2019. It was a unique collaborative effort, the first of its kind, because it was a teaching medical facility for residency, and it was the hospital initiative and also an FQHC VNA. And it really was close. It's down in the heart of the borough within walking distance, and really meets the needs of the community with culturally sensitive and language appropriate services. Provides comprehensive primary and specialty care. It's a state-of-the-art environment, and it provides patient navigation services. And even more importantly, it's co-housed with the VNA's Children, Family and Health Institute, which works with WIC, pregnancies, and children that are struggling with education. So while we were going through construction and this process was moving forward, the 3 entities in particular, the Freehold Health Department and VNA and Central State, saw an opportunity with the Robert Wood Johnson Foundation and the Culture of Health grant. And we decided as a group that we would apply for that grant to begin to try and address the social determinants of health within the community, knowing that, you know, VNA is not necessarily, that's not their emphasis, it's not the hospital's emphasis. And we certainly as local health departments struggle to, be able to know how we can do that. So we actually applied for a grant in 2017, of which we got. That grant provided boundary spanning leadership training, which allowed the 5 of us to understand, bringing different coalitions and community partnerships together and working through your different motivations and what brings you there. And I just wanted to emphasize that this particular initiative or coalition was really community driven versus organization driven. I know there were other communities that were awarded, but they were primarily organization driven. It's kind of like the hospital coming out and saying, we want to go for this grant, but it's really the hospital going for the grant as opposed to the community. And I want to emphasize that it was really the relationship that we had in building this FQHC that really the 3 entities really understood, the value of why we all had to wear equal hats in moving this forward. And out came a coalition that is now a current 501c3, Neighborhood Connections to Health. So Neighborhood Connections to Health is a community-based organization that works to build community partnerships to connect all freehold residents to healthy living. So really their drive is to address the social determinants of health by educating and by providing healthy foods. They work towards the built environment, biking and walking, applying for grants along those things. And in addition, they also provide intergenerational support. So the idea of combating loneliness, wanting people to feel included, and mixing the generations within the community to provide a more wholesome and engaged community. With this particular organization, there is a board of health. Connections, there is a board of directors. And of that board of directors, early on for the first few years as the health officer, they requested that I be the chairperson, because I was a neutral party within the coalition and would help balance us and keep us focused on public health initiatives. Again, this particular organization has strengthened our relationships within the community. I believe there's over 60 organizations that belong to this particular coalition. It's public health driven and it's trusted by the community, which is the most important. They are well trusted by the community, and as a matter of fact, other organizations see their trust and actually financially support this organization so that they can help get the work done and meet those populations or those people that are vulnerable and get those things done. So it's an effective organization. So I talk about new adventures because really it's the latter part of the FQHC was very important and those relationships were great, but really it's where we took the next steps. And again, over the last 5-6 years, those relationships continue to grow. We have been able to get assistance with vulnerable populations, vaccinations. We did that during COVID, and Neighborhood Connections to Health was very instrumental in reaching those individuals. As a health department, if I'd like to hold a vaccine clinic, that's great, but I'm not going to get the undocumented residents who don't trust me to come out and to do that. And Neighborhood Connections and that relationship is very important. This year, we've started working to improve access to care. So we made this great family health center, FQHC, in our community, but it's underused. People aren't seeing the value. They don't understand the amount of services. So we are actively working to improve access to care there by really even literally helping people make appointments, talking to them about their concerns, who are their primary providers, really trying to bring them into the fold. Financial support, I mentioned, Central State and VNA both submit or provide substantial funding to the organization to help keep it staffed. And even the health department, we have provided over the last few years support to help us connect so that we can meet vulnerable populations with the vaccines. And even more recently, we're just about ready to start working with the Women's, Infants and Children's with VNA and provide childhood-led screening to try and complement the work that they're doing and to have access to children that could have that lead screening. In Freehold, typically, many of the physicians will write a script for the parents to take the child, and oftentimes that screening is not accomplished. So we feel by bringing in some type of point screening at a center where the child is, if we can prick their finger and get a lead reading, and we know there's a risk, then the nurse can work with the parents to make sure the child gets in for confirmation blood lead screening. So just in general, to wrap it up, really, what lessons did we learn and I have learned? First of all, it's important to value your partners in the community, right? We need to seek opportunities and use the talents of other leaders and their missions. So, you know, again, if we know we're looking to improve access to healthcare in the community, I'm not going to be the one who's going to be able to do that necessarily, and nor should I as a local health department, right? I am the last of the decision, but with increasing insurance and increasing clinical access, we shouldn't be doing that work. We should be referring it on. And I have to respect what motivates people, right? We have to understand that, you know, everyone's in it for their own good, right? The Central State's looking to make a buck. VNA's got a mission. You know, we have a mission. Schools have a mission. Government has a mission. It's being able to understand what motivates them and understand that we have to work within that limitation. And then we need to share the vision as a community. It's important, the symbiosis, right? Look what we can do together. You know, we can't do it necessarily all by ourselves, but together we can make a difference. I think you have to give what you can. You have to use every opportunity to assist the partners in their goals. And in fact, many times I've written many grants with NCTH, which is Neighborhood Connections, to help writing and keeping them grounded in public health. I've worked with VNA on several grants, again, to help keep them grounded in public health. And again, we value each other. I value what they can do and what, you know, the services they're able to provide. And they really appreciate the fact that I get that public health slant and they're doing the work that they should be doing the way it needs to get done. And obviously give your time and celebrate, right? We need to celebrate, appreciate the small steps. When as a health department, or you're looking at, you know, trying to make a difference, and you know that there's a lot of social determinants and other things that are getting in the way for people reaching ultimate health, appreciate the small wins that we get, recognize other people for their roles. And, you know, I can quietly lead as a public health strategist. I see my role as quietly leading really from behind, right? In the sense that, you know, push people in the direction that we think we need them to go, but it's not about what the local health department's doing and how we're accomplishing that. It's really about getting the community to respond and getting that and having them thrive and be empowered. And really rejoicing at other people's successes. So if I went for a grant, someone else went for the grant, be happy that someone else got it. They obviously were better qualified to make that happen. So with that, I thank you, and I'm happy to take any questions.
Thank you, Marty, so much for your wonderful presentation. So we just have a few minutes. We have someone here that asked, so they basically said they're the director of the Student Health and Wellness Center at NJCU University. They're looking to improve their student health and advocacy efforts for the staff and community. Any collaboration opportunities?
Can you repeat it one more time? You were just a little muffled on my speaker here.
Sure, no problem. This person mentioned that they are the director of the Student Health and Wellness Center at NJCU University. They are looking to improve the students' health and advocacy efforts for the staff and community. Are there any collaboration opportunities?
I think, you know, maybe one of the things I would suggest is really even reaching out to the local health department and having that conversation, right? And we can look at other FQHCs and hospitals. You know, it just depends upon what other organizations within that community and what their interests are. Again, understanding what motivates them. But, you know, obviously too, some of those organizations have understanding. You know, I look at Trenton and they knew that they had some funding to support the school system. And so, you know, that ended up becoming a great partnership that they could work together to achieve that. And there are other opportunities out there. And my thought is, you know, start with the health department, reach out to them and find out who they know in the community that might be able to help make connections for you.
I'd also like to add, there's the New Jersey College Health Association for any college health professionals can join. We also have the New Jersey Immunization Network, which is a collaboration with the New Jersey chapter of the American Academy of Pediatrics. And in Essex County, there's the Essex Metro Immunization Coalition. So anyone who works in Essex County can join that. And I can provide further information to Kendra to share with all the registrants about those organizations.
Better answer. Thank you.
Thank you, Zachary. Do you need medical assistance?
Excuse me?
So someone asked, do you need medical assistance? I'm assuming that this is a question in terms of something you must have mentioned while presenting.
Do we
So
need?
I'm not sure why they asked this question. Maybe I'll type an answer, a question. I'll reach out to them privately to find out why. So we'll just move on from that, and then I'll get back to you with that, Margie.
Okay.
Okay. Okay, so Margate is the health center registered with NJIS to access the VFC and 317 programs. What steps has the center taken to improve trust with the undocumented?
They have provided navigators. So, in fact, in addition, the Neighborhood Connections to Health has a healthcare worker who actually comes and works with the navigator within the center. And so between them, they make those connections and bring them in. And then they have obviously Spanish-speaking people who assist with the Spanish-speaking physicians who can help with that. So it's by word of mouth and by a good experience. One of the things that we've done as well is that we do have a group. In fact, we meet this afternoon. We meet once a month, a group of the health department, Neighborhood Connections, the Federally Qualified Health Center, actively work to discuss some of the barriers and issues that the clientele are facing. And again, because of the trust of the navigator and the other and the community health worker actually get that firsthand information. And so we're working as a team to try and improve those issues.
Okay, great. Well, thank you so much, Margie. I know we're at the end of your presentation. Before I move on, I just want to make a quick announcement. If any NJDOH staff has any additional comments or clarification that needs to be provided, we have someone that wants someone to clarify some VFC information. Also, I also wanted to share that just to keep in mind, part 1 of the conference includes information on, NJIS and VFC for those who have not had the opportunity to check out the recording. The recording is located on our YouTube channel, and I'll share that at the end of the webinar. So now I'm going to introduce Zachary Elridge. He is the last presenter for the day. As he's sharing his slides, I'm going to take this time to briefly introduce him. So Zachary Elridge is an accomplished public health professional with over 10 years of experience in the field. He currently serves as the Adolescent and Adult Immunization Coordinator with the New Jersey Department of Health's Vaccine Preventable Disease Program, where he works to prevent the spread of VPDs by developing and implementing immunization campaigns to improve vaccination rates within the adolescent and adult communities. So Zachary, please take it away.
Thank you, Kendra. Can you see my screen?
Yes.
So thanks everyone for being here today. So as you heard about childhood immunizations, I want to expand on some of those, as well as talk about some adolescent and adult immunizations and some of the programs that we're doing in New Jersey. So as you know, immunization is a critical public health measure that saves lives and prevents the spread of infectious diseases. And in New Jersey, we're proud to be at the forefront of immunization initiatives. So in this presentation, I'll share with you some of the key initiatives that New Jersey is implementing to build immunity and confidence in our communities. And I'll also discuss some challenges we've faced and lessons we've learned along the way. So we're proud to have a dedicated team, and I'd like to introduce a couple of them who work in population assessment and health education. So myself, Zachary Ehrlich, I'm the Adolescent and Adult Immunization Coordinator. We have Jenny Sadakrin, who's the Population Assessment Coordinator. Jennifer Smith is a public health educator. Elisa Rossetti is a program support specialist, and Charlene Henderson is a COVID-19 health educator. We also have Aaron Rosenbaum, who is a statistical analyst. So our objectives for this presentation are twofold. First, we want to showcase New Jersey's current immunization initiatives and highlight the state's successes in promoting vaccination coverage. And we also want to aim to provide attendees with resources for implementing effective immunization programs. By providing attendees with resources and tools, we hope to empower them to create effective and sustainable immunization programs in their own communities. So I'll now talk a bit about some of our services, some of our data, and our programs. The Vaccine Preventable Disease Program is housed under the Communicable Disease Service within the Division of Epidemiology, Environmental and Occupational Health in the NJDOH. Our mission statement, the Vaccine Preventable Disease Program works to reduce and eliminate the incidence of vaccine preventable diseases affecting children, adolescents, and older adults by raising the immunization coverage rates of New Jersey citizens. So through our efforts, we're working to ensure that every citizen of New Jersey has access to the vaccines they need to stay healthy and protected. We do this by collaborating with healthcare providers, community organizations, and other stakeholders to raise awareness about the importance of vaccines, increase vaccine access, and improve vaccine delivery. We also work to educate those on diminishing vaccine myths and reducing vaccine hesitancy. So we're proud of the progress we've made so far, but we know there's a lot of work that still has to be done. So as part of the efforts to promote immunization and protect public health, we offer a range of services that are designed to meet the unique needs of our communities. Here are some of the programs we offer within VPDP. So first we have NJIS, the New Jersey Immunization Information System, which is our state database, and it's the official immunization record in New Jersey for individuals of all ages. The system allows healthcare providers and public health professionals to access immunization records quickly and accurately, and it helps to improve immunization coverage rates by accurately inputting that information. Secondly, we have our perinatal hepatitis B prevention program, which is designed to prevent the transmission of hepatitis B from mother to child. And this program offers testing, treatment, and education services for pregnant people and infants. We have our Vaccine for Children program, or VFC, as you heard about a bit today, which provides free vaccines to eligible children who may not otherwise have access to them. We have our population assessment program, which helps to better understand the immunization needs of our communities and assesses them through targeted interventions. We also have a strong epidemiology and surveillance program that allows us to monitor vaccine preventable diseases and identify outbreaks, and allows us to respond quickly and to take measures to prevent the spread of disease. We have a robust health education team who works across all programs within CDS and creates a lot of the wonderful flyers and pamphlets and videos that you may see. We also have our infectious and zoonotic disease program, who works very closely with all the other programs in VPDP. So now let's talk a bit about some of these services in more detail. So our Vaccine for Children program and our 317 program. So VFC is a federally funded program that provides vaccines free of charge to eligible children who might not have access to them due to financial barriers. So this program is available to children who are Medicaid eligible, uninsured, underinsured, who are American Indian or Alaskan Native. So all ACIP recommended vaccines are available through the VFC program. And by providing these vaccines free of charge, we're able to remove financial barriers. And in 2022, we distributed 1.6 million doses of vaccine through the VFC and 317 programs. So in addition, the 317 program, it provides federally funded vaccines to uninsured and underinsured adults. And both the 317 and VFC programs are critical components of our efforts to promote immunization and protect public health. So a bit more about NJIS. So it's crucial that we link stakeholders to vaccinations and that those doses get captured. So NJIS is the official immunization information registry for New Jersey residents, as I mentioned. It's one of the key features is reminder recall capability, and it allows healthcare providers to send reminders to patients when they're due for routine vaccination and subsequent doses. So this helps to ensure that patients stay up to date on their vaccinations and that they receive the protection they need against vaccine preventable diseases. So as several of my colleagues have mentioned, we really want to make sure that their targeted doses are spaced appropriately, and this reminder recall feature can do so. In addition, NJIS is a helpful tool for healthcare providers in locating a child's immunization history and forecasting future doses of recommended vaccines. This makes it easier for providers to administer vaccines on schedule and to ensure that children receive the vaccines they need to stay healthy and protected. It's also important to note that currently in New Jersey, healthcare providers are only required to enter vaccination records for those under the age of 7. However, we encourage providers to continue entering records for patients of all ages and to ensure that their records are complete and up to date. So one way to access your personal healthcare record is through NJIS, and you have your little yellow card or some other record that your healthcare provider has given to you. But if not, we recently have the Docket app. So it's a CDC approved application. That's an important tool for accessing immunization records in New Jersey. It adheres to federal and state standards for data security and privacy and ensures that patient information is kept confidential and secure. So Docket supports all vaccinations that have been entered in NJIS. So when the COVID pandemic first broke out, you could only use Docket to access your COVID-19 vaccination records. But we're working to integrate all relevant vaccinations within your personal record into the Docket app so you can pull them up easily. So we're also rebuilding our IQIP program, the Immunization Quality Improvement for Providers. So it's currently been paused during the pandemic, but we expect to have more information and get it up and running this year. The IQIP process is an essential tool for VFC providers who want to improve immunization coverage rates and ensure that their patients receive the best possible care and protection against vaccine-preventable diseases. So if you're a VFC provider in New Jersey, we encourage you to attend the next IQIP meeting when they're announced and attend the site visits. The IQIP process provides a comprehensive review of your vaccination workflow, vaccination rates, followed by discussion of key strategies to identify areas for improvement, address any gaps, and improve vaccine uptake. So earlier there was a question in the chat about the AFIX reports, and these will be shared again once our IQIP program resumes. So now I'd like to talk a bit about some of the tools we've created to aid healthcare and public health workers to assess their vaccination practices and improve them. So across the country, as some of my colleagues have mentioned, vaccination and routine vaccination rates have dropped significantly during COVID. Many adolescents missed their routine immunizations. There's been increased vaccine hesitancy. And data in New Jersey shows that from 2020 to 2021, we have an annual immunization status report, which indicated 7.3% decrease in 6th grade students meeting all immunization requirements. And this was a drop from 95.8% to 88.5%. So it's a critical time to ensure that adolescents are up to date on all routine immunizations, since many routine vaccinations were missed during the pandemic. So we developed an adolescent immunization facility level report. This report provides data for routine adolescent immunizations and was developed to help assess current immunization practices at healthcare facilities. This report was only administered to those who are enrolled in VFC, and data was assessed from NJIS. And so the report includes doses administered for Tdap, tetanus, diphtheria, and pertussis, HPV, human papillomavirus, and meningococcal conjugate MenACWI vaccines. So any vaccines that were not entered in NJIS were not accounted for in the rates in this report. So all doses of routine adolescent vaccines were assessed for trends at the state level, and the data was further analyzed to assess providers in identifying 5-year trends within their facility, and they were emailed individualized reports. So if you believe that you should have received one of these reports, please email me and I'll let you know. We did cut off the reports for those who had a minimum of 20 Tdap doses to have something to analyze the data with and to account for statistical significance. So the report presents data from NJIS, but it cannot account for external factors such as transient patient populations, patient refusals, or other events. And while we recognize that there may be other factors at play, the report was shared to shed light on current trends in vaccination administration in your current practice. And please be aware that implementing best practices such as reminder recall function in NJIS or utilizing standing orders can help increase immunization rates. So if you currently participate in these practices, it may take some time to see the results of your efforts. We also want to remind you to keep your email addresses of your staff up to date in NJIS. so that emails are sent to the correct place and not potentially move to your spam folders. So we also have an HPV vaccination assessment tool, which was developed to track HPV vaccine coverage by healthcare providers. So there's an image of the tool on the left here. So there's also an on-demand tutorial that's integrated into NJIS in the training section to learn how to use this tool. The tutorial is intended for healthcare providers who administer adolescent immunizations. In terms of our target HPV age range of 11 to 12. And while healthcare providers may administer doses as early as 9 or catch-up doses as late as 45, as discussed earlier, this tool is really for that 11 to 12-year-old target range. The tool provides important reminders on how to improve HPV vaccination, tips for talking to parents about vaccine, as well as a vaccine dose assessment table on the bottom right here. The on-demand tutorial provides a step-by-step guidance on how to complete the tool. And as Dr. Schwab mentioned before, one of our greatest strengths in increasing HPV vaccination uptake is a strong healthcare provider recommendation. And so also in an effort to aid healthcare providers in entering vaccine doses in NJIS and improving immunization rates, we developed these 2 tip sheets that were shared with healthcare providers and posted to the NJIS bulletin. So we have one here on the left for best practices for providers and one here on the right for best practices for providers to improve adolescent immunization rates. So we also have immunization standards, both for pediatric and adolescents and one for adult immunizations. So these are 2 very comprehensive tools to help with vaccine assessment, communication, and storage within your facility. So it's very important to ensure and maintain quality in the healthcare domain, and it's critical to positive patient outcomes. So standards were developed to set forth what constitutes the most essential and desirable policies and practices. So the guides include self-assessment tools to help healthcare professionals gauge their performance and identify areas for improvement. The tools cover various aspects of immunization practice, such as availability of vaccines, assessment of vaccination status, effective communication about vaccine benefits and risks, proper storage, administration, and documentation of vaccines, just to name a few. And the guides really encourage healthcare professionals to conduct routine self-assessments as a method of continuous quality improvement. And they also provide resources and action plans to address identified gaps in performance. And by adhering to these standards, healthcare providers can help ensure that their patients receive the best possible care and protection against vaccine-preventable diseases. So we encourage you to take a look at some of these, and we have them listed on our website, which I'll have with my final slide here. So as healthcare providers and public health professionals, it's also important to stay up to date on the latest recommendations for immunizations. So recently, the CDC updated the immunization schedules for children, adolescents, and adults. So on the left here, there's images of the immunization schedules, and on the bottom left is the website for the schedules. So overall, these updates to the immunization schedules reflect the latest research and recommendations for immunizations. And we encourage all healthcare providers to review the updated schedules and ensure they're providing their patients with the most up-to-date and effective immunizations possible. So going hand in hand with the immunization schedules, we recommend if you don't like to have them carried around with you all the time or need a quick reference, there is an app for the CDC vaccine schedules available on Apple and Android devices. And it's a free app, and it allows you to very quickly look at the schedules. You can click through the catch-up schedules. You can look at contraindications and precautionary tables. And it's much more easy to click on the links versus skimming through the entire schedule. So to ensure that we're making evidence-based decisions and tracking our progress, we rely on a variety of data sources related to immunization. These data sources provide us with valuable insights into immunizations and coverage rates, vaccination trends, and other important indicators of public health. So here are some of the data sources that we utilize on a routine basis. So we have the CDC National Immunization Survey, referred to as NIS. So it provides immunization on vaccination coverage rates among children and adults in the US. We also have the VaxView, which is also from CDC, which is an online dashboard that provides data on vaccination coverage rates across the country, and you can toggle on different vaccines, such as routine childhood immunizations or flu. So we also have the Pregnancy Risk Assessment Monitoring System, or PRAMS, and it's a survey of women who've recently given birth. It provides information on maternal and infant health, and including their immunization status. We also have the Behavioral Risk Factor Surveillance System, or BRIFIS, which is a survey of adults that have provided information on health-related behaviors and chronic health conditions, including vaccination status. We also have New Jersey State Health Assessment Data, NJSHAD, which is an online data portal that provides access to a variety of health-related data, including immunization coverage rates. And we also have a couple of internal reports that we produce, such as the annual status report, the local health department immunization audits, and the college health status report, which are all administered and analyzed by us at VPDP. I recently emailed the current findings of the college status report a few days ago through links messages. These data sources are open access to anyone who wants to use them to look at the data and assess them how they choose. So by using these data sources, we're able to make informed-based decisions and track our progress and identify areas where we need to focus our efforts. So using data from these sources, I want to mention that we quickly produce several specific data briefs for New Jersey. This one is the adolescent data brief. It illustrates that we have met the healthy people target for many CWI and Tdap vaccinations, but we still lag behind in HPV and flu vaccination rates. So for a full overview of the data briefs, please visit the links on the bottom left of these pages, or go to our VPDP website for the links to the data briefs. So we also have the adult data brief that illustrates that New Jersey has met its goal for flu vaccination for those ages 65 plus, for zoster, but it still lags in target goals for flu vaccine for those ages 18 plus, pneumococcal vaccine 65 plus, and is behind in national rates for TD or Tdap vaccination. So we're proud to run several wonderful campaigns that aim to promote vaccination and protect public health in New Jersey. Our campaigns are designed to raise awareness about the importance of immunization and encourage individuals to get vaccinated on schedule. And we'd like to encourage you to explore our campaigns and find one that resonates with you and participate wherever you see possible. So whether you're a healthcare provider or a public health practitioner or member of the public, there's many ways to get involved and make a difference. A lot of these campaigns, we work directly with a lot of our health service grantees, including the Partnership for Maternal and Child Health of Northern New Jersey, the New Jersey Immunization Network, as I mentioned before, just to name a few. So the Hot Shots for Tots immunization campaign is a voluntary points-based incentive program for childcare and preschool facilities. It encourages and facilitates collaboration with immunization stakeholders to promote best practices and improve immunization coverage, not just among students in childcare centers, but also among the staff as well. So participating facilities conduct immunization-related activities to earn points towards reaching one of the 3 award levels: gold, silver, or bronze. And examples of qualifying activities include attending an annual immunization workshop, participating in NJIS, and providing information to parents about childhood immunizations. So the current Hot Shots for Tots campaign is just winding down right now, but stay tuned for information about next year's campaign. We also have Protect Me with 3, which is in collaboration with the Partnership for Maternal and Child Health of Northern New Jersey. So this is a youth-targeted campaign, which consists of a social media campaign, and we have an educational website with information for students, but also information for their parents and their teachers as well. So within the campaign, students are asked to create and submit posters or videos about One of the adolescent immunizations, we have 5 that they can choose from. Tdap, MenACWY, flu, COVID, or HPV. And they can either create a hand-drawn poster or a digital poster, or they can create a video that's 30 seconds or under, explaining the importance of immunization and why immunization matters. So these are the winning posters for the most current year. So here on the left is the winning high school poster, and on the right is the winning middle school poster. And so we have a great incentives for this contest. Winning prizes range from a $50 to a $300 Visa gift card for those who are finalists in terms of first, second, and third place, or we also have honorable mentions. We also have awards for teachers who have the most eligible submissions within their classroom. So we not only want students to be aware of immunizations and why they're important, but also get their parents involved, help them be educated, get the students, teachers involved, and really make it a whole class project if possible. So I'd like to share with you now the winning high school video for this year. Hopefully the audio plays.
The flu is a highly contagious respiratory disease that affects the lungs and throat and nose. Body aches, coughs, fever, chills, headaches, and sore throat are symptoms of the flu. Every year, 41 million people get sick and 52,000 die. The best way to prevent the flu is to get a flu vaccine.
Create, educate, vaccinate. Talk to your parents about getting vaccinated. For more information, go to www.protectmewith3.com.
So we really have a wonderful group of submissions. Some of the videos are super creative and really impressive. These videos will also get posted to our YouTube page, and the winning posters get printed on official DOH letterhead, and they get mailed to all the local health departments, as well as to the students themselves. We also have another campaign called the New Jersey College and University Flu Challenge. So it's an initiative that aims to improve flu vaccines specifically among college students. Since young adults have been shown to have lower flu immunization coverage rates as compared to other age groups. And in addition, college campuses have a lot of communal settings, which makes it easier for flu to spread super rapidly. So if a college student gets the flu, they can miss class, causing them to miss information, which hinders their education. They don't want to get other people sick. So for those reasons, it's extremely important to bring added awareness to the benefits of flu vaccination. And the challenge encourages friendly competition between institutions that, and we determine which campus can achieve the highest flu vaccination rate simply by a student survey and how many students they have total. So each participating college develops and implements a unique influenza campaign that fits the needs of their student body. And by participating in the challenge, institutions receive access to educational resources. We have a welcome packet, and they also have a chance to win a traveling trophy for this year. So the winners from the most current year, which just wrapped up a couple months ago, in our large school category, we have New Jersey City University. In the medium school category, we have the College of New Jersey. And the small school category, we have best care colleges. So congratulations to all. We also have the Influenza Honor Roll, which is another flu promotion campaign. So it's open to 4 categories, which is institutes of education, businesses, or community-based organizations and medical facilities. So these groups are encouraged to submit applications detailing their flu-related activities that were implemented during the flu season. And everyone who is named to our honor roll gets a certificate of recognition and named on our website. So here are the honorees for the most current year. So congratulations to all, and please be on the lookout for information next year for the College Flu Challenge and the Influenza Honor Roll as well. So one of the most frequent questions we get is how can we stay up to date on information, and how can we know when information is happening and when the campaigns are launching? And that's really to enroll in our NJ Links messaging system. So it's essential for healthcare providers and public health professionals who want to ensure that they receive timely updates and information. So this is one of our main forms of mass communication and acts almost as like a statewide listserv. So feel free to go to the link on the screen or scan the QR code. Anyone can sign up for links messages. You don't have to work in public health or healthcare setting. We really encourage all of our stakeholders who want to receive this information to enroll in New Jersey links message alerts. So if you have any further questions about any of our initiatives, our immunization programs, please feel free to call us. Our phone number is here, our website is here, or feel free to email myself or one of my colleagues. Our team is available to answer any of your questions. And together we can really improve immunization coverage rates in New Jersey and protect the health of our communities.